Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. As today we're going to talk about targeted therapy for non-small cell lung cancer going beyond EGFR. We have a great faculty today here for this program. Dr. John Heymach from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Professor Maurice Pérol from the Leon Birard Center in Lyon, France. Today we're going to be talking about targeted therapy of non-small cell, and as in all of our programs, we will be talking about the use of unapproved agents and regimens. So check out the package inserts for more information. As with all of our Year in Review series, I met individually with each faculty over the last couple of weeks to record presentations. We're going through a bunch of papers. Here are the papers that we go through in detail in these presentations. They're actually in the chat room right now if you want to check it out right now, but we'll also be sending it out with the replay of this webinar as really a three-part program. In these presentations, the faculty goes through in detail these papers. Tonight, I picked out some or a lot of the papers, but we're going to just really get into the clinical implications and also implications in terms of future research. Here's where we're heading. We're going to start out talking about HER2 alterations, KRAS, MET. Then we'll get into ALK Fusions, including the big adjuvant RET paper of selpercatinib at the ASCO meeting recently, ROS1 Fusions, and RET Fusions. But I was telling the faculty we like to do sort of a warm-up brain stretching activity as an introduction before we dive into the data. And I've been kind of thinking over the last week or so a lot about, actually I brought this up last week at the myeloma webinar. I brought up this program here tonight because when I was recording the presentation with Maurice, he put up this slide, which really caught my attention and made me think a lot. And we'll get more into ROS1 TKIs later on. But what I wanted to point out to you is when you look indirectly and compare all these many different agents that have been looked at, you can see that particularly in terms of median PFS, you start out 15 months with crizotinib and entrectinib. Then you get into the newer agents, and now you're looking at 46 months, and more taletrectinib, zidesamtinib, so much longer PFS. And Maurice was pointing out that, for other targeted therapy, for example, osimertinib by itself, you're looking at PFS of 18 months around maybe. Add on chemotherapy, get another 6 months, but nothing like what we're going to talk about, for example, with lorlatinib and ALK, almost 8-year PFS. I was telling the faculty that the myeloma program, we were saying last week that there was a standard risk typical myeloma patient, you're looking at PFS1 of 15 to 17 years. So huge differences in efficacy of targeted therapy, John. And Maurice brought up to me this idea in lung cancer that there's a big difference between fusions and mutations. So, for example, ALK versus EGFR, which we just mentioned, but also other fusions like ROS1. And so, John, I asked Maurice to start out to talk to me before, and I'm going to start with you, and then we'll come back to Maurice, what your vision is for why you see such a big difference in efficacy. And as we go along today, I'm going to ask you, where does some of the newer TKs, where does zongertinib fit into this idea? And do you kind of view these as the mutations and fusions differently and how you conceptualize them for a lot of things, John, even response to IOs, et cetera? So, John, I just want to give you that chance to just sort of chat a little.
Yeah, well, they're great questions. And I'll give as examples. Let's say we talk about EGFR and ALK. The first thing to note is medicinal chemists are really good at their job, right? So you see this steady improvement, and I just want to recognize the great effort that pharmaceutical companies and medicinal chemists put in to just keep tweaking these molecules, get rid of side effects, get better brain penetration, to keep improving them. So in part, it's just this relentless focus that they're all getting better. But mutants like EGFR are small changes in the kinase pocket of EGFR. And so the differences between the regular or wild type EGFR and the mutant EGFR are not that huge. It's 1 or 2 amino acids different, right? You take a common EGFR mutation, it's an L858R. That means one amino acid, the L, changes to an R at that one position. Fusions, on the other hand, are entirely new creations where the chromosome breaks and then it refuses at two new places. And so, when we've been trying to make drugs, we're trying to make them inhibit a mutant, but not inhibit what's normally active in the body. And so one of the differences is the difference between mutant EGFR and regular EGFR, wild type EGFR, is pretty small. It's hard to inhibit one without the other. Whereas with something like ALK, you can really inhibit an ALK fusion very potently without a lot of side effects on the rest of the body. So I think that's one big difference. You've got a bigger margin for error because you're not as worried in the case where you create a brand new fusion of inhibiting the regular kinase there.
So that's very helpful. Maurice, anything you want to add to that? Also, in terms of looking at some of the alterations that we're going to talk about today, we showed your slide there that showed the big difference between crizotinib and now the third generation. Was like, what's the difference? Why do you see such a great increase in PFS there?
Well, I agree with John's comment. I think that the improvement in the drugs are made probably because at the time when crizotinib was discovered and evaluated, we didn't know anything about the ROS1 fusion. It's after the identification of fusion that with the advances in chemistry, it was possible to build more targeted drugs, more potent, with a better CNS penetration. And we have, in fact, less problem with side effect than for mutation because the difference between the wild type protein and the mutated protein are very small. So it was easier to clearly to change the natural history of the disease with fusion. This is the main example is ALK positive disease, but the ROS1 story is very similar to that of ALK positive disease, with a clear improvement in the design of the drugs, which are clearly more potent, and probably the on-target resistance in the fusions probably occurs a little bit later and are probably easier to target with the new generations of drugs, explaining that probably it was easier to prolong PFS and to prevent the emergence of resistance mechanisms with the fusion in a more potent way than for the mutations.
So we may refer back to this idea as we go through these various alterations that we're going to talk about today. We're going to start out, though, talking about HER2 alterations. And John, actually, I was mentioning tomorrow night we're doing a program in breast cancer and HER2 positive breast cancer. I was going to show them tomorrow night this program we did, HER2 testing and breast cancer management, 2003. Had a CD and a cassette. That's how old it is. So anyhow, HER2's been out there a while, and now it's all over lung cancer. And I love this graphic that you put together, John, really showing sort of the history of how this evolved, first with TDXD, particularly with HER2 mutant, and now zongertinib, the TKI. Can you kind of just talk about where we've been and where we are now, where you think we're heading?
Yeah, well, the first thing to point out is, there's a lot of docs out there that are familiar with treating HER2 amplified breast or GI tumors or other types. In lung cancer, the driver tends to be HER2 mutations, not HER2 amplification. And so they take different drugs in part. For a number of years now, we've had trastuzumab deruxtecan, again, a drug that's a lot of people have experience with from breast cancer and other tumor types, in the setting of lung cancer, in the setting of platinum refractory disease. And our TKIs just weren't good enough. In fact, we studied one for a number of years, poziotinib. But the problem is that the HER2 mutants and EGFR mutants are very similar. So the drugs that inhibited HER2 often inhibited EGFR, so you got all these EGFR toxicities. So now through engineering these molecules, they finally have made a generation that are much more selective for HER2 and can inhibit the HER2 mutants, which are harder to inhibit than the regular wild-type protein. So, I think the big advances now in this space, we have two TKIs. We have zongertinib and sevabertinib. Now, zongertinib is very specific for HER2. It doesn't inhibit EGFR, so you don't get the EGFR toxicities like the acne and the diarrhea. Sevabertinib does inhibit EGFR to some extent. So that's one difference between them. But the drugs first got approved in the second line setting after platinum doublet chemotherapy. So that meant now we suddenly had a choice. After platinum doublet, you could use trastuzumab deruxtecan, zongertinib, or sevabertinib. And then just in the last couple of months, zongertinib has gotten approved in the first line setting before chemotherapy. And that was based, on the median PFS of about 14 and a half months. So, now we have a whole new paradigm. You start with the TKI, zongertinib. Then you've got a choice, chemotherapy or trastuzumab deruxtecan or sevabertinib afterwards. So, I think we're going to have to relearn how to treat these patients. And, there's a lot more now about sequencing that we're going to have to figure out.
So, Maurice, I guess kind of looking at this with my new view, thanks to you, of targeted therapy, this kind of looks, the zongertinib kind of looks like it's falling more into the osimertinib model here. It looks like a PFS of 12 months, or maybe it's going to be longer than that. And also, it's been approved specifically not just for all HER2 mutant, but TKD mutations. What do we know about efficacy in non-TKD mutations? But first, do you think this sort of follows the mutation type of TKI concept you were talking about?
Well, for the HER2 mutants in non-small cell lung cancer, the vast majority of those mutations are in the TKD domain. So it's the mutations which are located outside of the TK domain are very rare, and I think it's probably more logical to target with zongertinib the mutation in the TK domain, which is maybe not the case for trastuzumab deruxtecan because the mechanism of action is, of course, quite different. Zongertinib is a very interesting drug because of its safety profile. It is a very well-tolerated drug. Among all the TKIs we have to give to our patients, this is probably one of the easiest drug to give and to tolerate for the patients. And as John mentioned, it's very difficult to target HER2 mutation because of the issue of EGFR-dependent toxicity. And clearly, with zongertinib, we avoid this toxicity. And this is, the reflex to give the TKI in frontline is clearly the easiest way to start the treatment for a patient with HER2 mutation.
So I'm going to just sort of flip through the slides, some of the slides from John's presentation. Hopefully you'll check out the presentation for more details on that. But John, Emily in the chat room wants to know about TKI like zongertinib with HER2 amplified, what we know about it. I want to know, and I'm going to ask the faculty tomorrow night with breast cancer. I know zongertinib has been looked at in breast cancer. Are we potentially looking at, breast cancer is only 4% of all, HER2. Could we potentially be looking at a pan-tumor approval for zongertinib for TKD mutant disease? Do we know whether or not you see responses in other tumors, John? And what about this question of just overexpressed?
Yeah, in the case of overexpression in lung cancer, HER2 doesn't tend to be a driver in the same way. And by driver, let me explain what I mean. When we think about a driver, it's usually that if you inhibit the activity, the tumor, mainly disappears or mainly dies, right? With HER2 overexpression, HER2 may be making the tumor more angry, so to speak, but you don't get the same response rate with the TKI with HER2 overexpression. So there clearly is activity, but it's not going to be as high as it is for the mutation. By contrast, I think the HER2 overexpression is where I would lean towards the drugs like trastuzumab deruxtecan right now, but there is a lot more to come. And the other thing is there's going to be TKI combinations as well. It's being studied in combination with trastuzumab deruxtecan. It's being studied in a lot of different combinations. So, my guess over time is that the overexpressed or amplified are going to require zongertinib combos but the TKI is really where you get the monotherapy activity that's very high.
So Maurice, Hassan in the chat room wants to know about zanidatamab, of course, now approved in biliary tract cancer, bispecific targeting two parts of the HER2. Also, just first-line data in gastroesophageal. Looks like it's going to be first-line therapy there. What about zanidatamab in lung cancer? And also, getting back to the model of targeted therapy, osimertinib, here's some data with zongertinib in brain mets. What a great-looking waterfall plot. I assume that you're going to maybe apply the same kind of strategy. Patients without CNS symptoms, maybe holding off on radiation therapy and treating patients with these HER2 mutations. So, Maurice, any comments on zanidatamab and these TKIs in brain mets?
Well, first, for the TKI in brain mets, I think clearly zongertinib demonstrate a good CNS penetration and clearly has a CNS activity, which is important in HER2 mutant non-small cell lung cancer because the brain mets, the incidence of brain mets at baseline and during the course of the disease is very high. So this is a very important point. For the zanidatamab, I think we do not have today enough data to really assess the room for this antibody targeting two epitopes on HER2. We tried in our academic group to treat HER2 mutant patients with a combination of trastuzumab and pertuzumab, and in fact it was not successful. So I would be more confident in ADCs and in TKIs for treating those patients with HER2 mutation.
So, John, I just showed a couple of slides with cevabertinib and also these really exciting first-line data with zongertinib that you referred to. What about cevabertinib? It looks like it has very good activity, but maybe a little bit more toxicity. In your algorithm there, you had also potentially a second line after zongertinib. Do we see responses in that situation?
Yeah, a great question. So, zongertinib in the first line setting, high response rate, 76%, median PFS about 14 and a half months. And as Maurice mentioned, well tolerated, almost no grade 3 diarrhea. I think there was one case. Cevabertinib was originally developed to inhibit EGFR exon 20 insertions and HER2 exon 20. So it does have that EGFR cross-reactivity. Still very active. In the first-line setting, the PFS was about 13 and a half months, response rate about 70%, but it did have higher rates of grade 3 diarrhea, and higher rates of rash as well. So I think that's really the liability of the drug requires a little bit more management, but clearly an active drug, far above the drugs we had prior to zongertinib. Now, about the sequencing, I think this is something that's still a work in progress. We do know that there are some resistance mutations to zongertinib that could respond to cevabertinib. One of them that had been reported on preclinical data is called the 805 mutation. Now, I'll just get into the weeds a little bit here. Zongertinib is what we call a covalent inhibitor, and it covalently links to HER2 at this particular amino acid, the 805 amino acid in HER2. Cevabertinib is not covalent. Now, sometimes that 805 gets mutated, so zongertinib falls out and doesn't bind anymore the same way, but cevabertinib doesn't. So, I think the big point is that having multiple choices is a good thing. Having zongertinib, cevabertinib, and TDXD is a good thing for patients, and we're learning how to sequence them optimally and when it might be appropriate to use one or the other after a different HER2 drug.
So of course, diarrhea seems to be a significant issue with zanidatamab, and it's great that you don't see that with zongertinib. It's also amazing how little investigators outside of lung cancer, even in breast, they know about the whole zongertinib story. It's like, I'm amazed. And, John, I was asking you before about whether maybe there'll be a pan-tumor approval. Like right now, if a doc in practice has a patient with another cancer, I don't know, endometrial cancer, breast cancer, whatever, with a TKD mutation,
yeah,
would you, if you could, would you try to get this zongertinib and treat him with it?
Yeah, great question. In the phase 1A, we did study different tumor types, and there was clear evidence of activity, in other HER2 mutant tumor types. And, for the HER2 mutants, drugs like tucatinib do not inhibit them very well. That's another TKI that had been available
Right.
for breast. So,
Daratinib,
it
same
would
thing.
be, yeah, it would be off-label use, but I would absolutely recommend trying to obtain it if somebody had a mutation, a HER2 mutation in another tumor type.
Yeah, we'll see what the NCCN says about that as well. So finally, Maurice, maybe you could just comment a little bit of, there's so much excitement now about these TKIs. We have this study now, the Beeman lung study, going to look at upfront treatment with HER2 mutant disease. What about TDXD? That was really the first first agent that was successfully used in the HER2 lung cancer. Where are we right now with TDXD, and where is it in your sequence of therapy in HER2 mutant disease? What's new in terms of ILD? That's a big concern, Maurice, with any tumor type with TDXD. And what's your experience giving the drug, particularly also in terms of acute GI toxicity? The breast cancer people are very, very aggressive about preemptive medication. Maurice, any comments about TDXD and lung cancer?
Well, I think among the ADCs that have been developed in non-small cell lung cancer, in terms of efficacy, TDXD is probably an outlier, but because it targets an oncogenic pathway in HER2 mutant, and we have also some level of activity in patients with HER2 3+ protein overexpression, and this is an agnostic approval across tumor types. And interestingly, EMA just recently approved also TDXD in HER2 3+ overexpression. In terms of efficacy, this is clearly a very, very active drug. In terms of safety, we have first, the issue of GI toxicity, but as we used to give, a lot of drugs like cisplatin and with a lot of emesis, with a very good premedication, it is relatively easy to control and to prevent this GI toxicity from TDXD. The main issue comes from ILD because it is common toxicity, which is dose dependent. The fact to reduce the dose from 6.4 to 5.4 led to a significant decrease in the incidence of ILD and also in the severity. I think there was a learning curve for the physicians for TDXD and ILD, with probably less severe ILDs during the most recent trials, because the vast majority of severe cases of ILD are missed early stages of ILDs. And this is the reason why we have to learn how to detect very early this toxicity. It seems to be experimental data suggests that it seems to be due to a target-independent uptake of the ADC by alveolar macrophages, and explaining that different ADCs targeting different targets but with the same payload, like deruxtecan, can lead to ILDs similarly to trastuzumab deruxtecan. But clearly we have to educate the patients, educate the physicians to be able to detect very early this kind of toxicity before it reaches the grade 3 or grade 4.
So, John, getting back to this idea of relative efficacy in terms of the next topic here is KRAS mutations. And I've got to say, initially when the data came out on KRAS G12C and some of the agents such as adagrasib, sotorasib, it didn't look all that impressive to me. It didn't look as effective as what we'd seen in the past with something like osimertinib. But now we're starting to see new agents. Also, the incredible presentation in pancreatic cancer of the KRAS agent with incredible activity. What about these new KRAS agents, John? How do they compare in terms of efficacy and tolerability compared to the first generation ones? So starting out with Morisib.
Yeah, this is an area we talked earlier about the evolution with TKIs. This is an area that's evolving faster than any other area in cancer. And the pancreatic presentation with daraxonrasib was a good example of that. So our first generation of KRAS G12C inhibitors was sotorasib and adagrasib. They're active. They deserve to be approved. But again, the activity was moderate. The median PFS about 5.5 months for both of them in the second line setting. So we've got the next generation of drugs. And I really think of divarasib and alomarasib as the two drugs that, whether you call them the second generation or how you name them is debatable. But these are clearly more active as monotherapy. And now we're going to have first line studies coming out in the near future of these drugs combined either with immunotherapy or immunotherapy with chemotherapy. So the one that was presented at ASCO was the Crescendo 170 study. So this was the Genentech compound is divarasib combined with pembro. Really high response rates, over 70% for the overall cohort. And in the PD-L1 negative group, and this is a group that doesn't respond very well to pembro by itself, about a 70% response rate of the combination of divarasib with pembrolizumab. So, really impressive response rate. And that's compared to the monotherapy where, response rates were high, but still not in that 70% to 80% range. As monotherapy was about a 55% response rate, again, combined with pembro, even in the PD-L1 low, about 70%. So really impressive activity. Now, we're going to see a randomized study in the future of divarasib pembro versus standard of care, which would be chemotherapy and pembro. And based on what we're seeing here, it'll be surprising to me if that study isn't positive. So that's divarasib. And for lomarasib, I think we have a similar study. That's called Sunray 1 study. And that's a lomarasib combined either with pembro by itself or pembro and chemo. So really, I think for everybody listening, I think the next two KRAS inhibitors that we're likely to see in non-small cell for KRAS G12C I would expect there's a good chance there'll be divarasib and alomarasib. There's another compound from Merck also out there as well. But I will tell you there is a tidal wave of new RAS inhibitors coming, and I've never seen so much creativity in molecular design as I saw, at ASCO with all the different types of molecules coming. So really view this as just that little wave coming up before a giant tidal wave that's going to wash over the field in the next several years.
So Maurice, any comments on, again, the way these agents are, why they're different than the first generation agents? Also, what do we know about CNS activity with these agents? Are we going to be able to use a similar kind of strategy of maybe using systemic therapy, holding off on radiation therapy? And what about tolerability? What kind of tolerability issues come up right now with the current agents, and how do the newer ones compare?
Well, clearly for the KRAS G12C mutations, this becomes a very crowded space with so many new compounds, and of course also for the other mutations of KRAS. In terms of CNS activity, we have at the beginning already some evidence of activity of the first generation TKI, especially well documented for adagrasib. We have also some evidence of good CNS activity for olomarasib in the phase 1/2 study. So I think we can reasonably expect that the CNS penetration of this agent will be good, and this will not be a limitation for their development. In terms of toxicity, this is the main point is the liver toxicity, and especially when you combine the KRAS G12C inhibitors with immune checkpoint inhibitors, because you have an increased incidence of transaminase elevation, and this is an overlapping toxicity for both the KRAS inhibitor and pembrolizumab or another checkpoint. And so you have to usually to stop both drugs and to wait for recovering of the toxicity. If it is a rapid recovery, you can expect that it is due to the KRAS inhibitor and you can restart with a lower dose level. Or if this is a longer lasting toxicity, you can expect that it comes from pembrolizumab and to start corticosteroids. But in clinical practice, even in the clinical trial settings, this is not so easy to manage this kind of toxicity.
So, John, on your talk, you also got into MET overexpression. Can you guys clarify, too, what the difference is between MET mutations and how they're targeted and MET overexpression? I know there have been past attempts to focus on MET expression that haven't been, I think a monoclonal antibody wasn't that successful. But now we have Teliso-V, the ADC. What subset is being targeted here, and what do you see in terms of efficacy and tolerability, John?
Yeah, well, you're right to point out the difference between MET mutations and MET overexpression. So the MET mutations that we think of as drivers are called MET exon 14 splice mutants. We just say MET exon 14 for short. And there's a particular set of mutations that cause the protein to be expressed at really high levels. And it acts like a driver, meaning you inhibit it with the TKI and responses are durable. We have capmatinib and tepotinib for MET exon 14 splice variants. Now, MET overexpression is much more heterogeneous, and it can happen in the setting of drug resistance, like resistance to an EGFR inhibitor. It can happen just de novo. It can be resistance to other types of drugs. So MET overexpression, you can get there a lot of different ways. And here at the ADC, this is Teliso-V, is now approved, but only for the group that has the highest expression, the MET 3+. Now, it was interesting to me because the MET 2+, the intermediate MET, had almost the identical progression-free survival, in that neighborhood of about 6 months. But the FDA approval is only for the overexpression. So regardless of what your patient has been treated with before, as long as they're previously treated, if they have MET overexpression, Teliso-V is a potential option.
So let's talk also about ALK, and this was covered by Maurice on his talk, a lot going on in ALK. First, we've seen updated data from the adjuvant setting with alectinib, the ALENA style trial, but here comparing it to chemotherapy. So Maurice, can you talk a little bit about what we know there and from that study? And then we'll also talk about the ALEX study comparing it to crizotinib. Anything you want to say about where we are right now with adjuvant alectinib, Maurice?
Well, the design of the ALENA trial was a little bit different from the design of other adjuvant trial in oncogene-addicted tumors because it was not compared to a placebo, but it was compared head-to-head to adjuvant chemotherapy given for 4 cycles. And with a longer update, approximately 4 years median follow-up, clearly the DFS benefit that has been demonstrated when there was early results is still there. And alectinib continues to demonstrate this DFS benefit, even if there are more DFS events at the time when you have to stop alectinib at 2 years, because alectinib is given for 2 years in adjuvant setting. And there are, of course, when you discontinue alectinib, there are more recurrences, but despite these recurrences, the benefit is still there at 4 years, and it is clearly a new standard of care now. It's too early to have to evaluate the impact on overall survival today. And for the ALEX trial, it was interesting to look at the overall survival benefit with the long-term survival. Clearly, you can see that alectinib was able to change the natural history of the ALK-positive advanced disease in comparison to crizotinib. Nevertheless, I would also like to underscore the fact that there was no crossover. The proportion of patients in the control arm with crizotinib, a significant proportion of patients did not have access to a second generation TKI at the time of relapse, and this has to be taken into consideration in the interpretation of the overall survival benefit. But overall, this is the first demonstration that with the second generation TKI, you change the natural history of the disease, you can achieve a median overall survival of 81 months. So this was the first demonstration that you can change the patient outcome by giving a more recent drug, a new generation drug.
So, John, can you talk a little bit about how things play out? I mean, I think the average general medical oncologist doesn't have the same opportunity to see as many patients as you do in terms of kind of what life is like when adjuvant alectinib, what types of tolerabilities come up in the long term with these patients, and any current or future roles for ctDNA in this setting.
Yeah, all good questions. First of all, I'll say that adjuvant alectinib is tolerable. People are able to manage with it. They do have some abnormalities with, lipids, for example, with their cholesterol levels. Sometimes they have a little bit of edema. I'd say the most common thing I run into with adjuvant alectinib is people just reporting feeling a bit fatigued. Sometimes it's not very specific, and it's hard to match. They're not anemic. It's hard to match a specific side effect with it. But that's probably what I run into most often. But again, patients are able to manage it. It's a tolerable drug. They should be able to carry out their normal activities with that significant limitation.
How about ctDNA? I'm not sure whether it's that useful with those. I hear some people talking about it with osimertinib. What about adjuvant alectinib?
I think it's a great point. I do this with my EGFR mutant patients on the ADORA study, the adjuvant osimertinib routinely, and I've just started doing it with alectinib, and I use it in the following way. After you've completed 3 years of osimertinib or 2 years of alectinib, you stop the drug, and patients often are concerned after stopping the drug. They're concerned they're going to have a recurrence. And we know ctDNA can identify the recurrence before you see it radiographically. So the assumption, and it's not proven, but the assumption is if you restart a TKI before you can see the disease come back, you may be able to keep it down for much longer. So I do use the ctDNA assay for patients after they stop adjuvant alectinib or osimertinib. And, if we do see a recurrence, I think we would likely restart it at that time.
So let's talk a little bit about metastatic disease. But first, from the chat room, Maurice, Shoba wants to know about myositis in alectinib. Do you see that in this adjuvant situation? Hassan also wants to know, we'll get into this with the adjuvant RET trial, are we going to need to do a phase 3 adjuvant trial for every type of a mutation? Or can we just, people are saying, why do we need to keep doing these phase 3 trials? We know what they're going to show. Any thoughts, yes, Maurice?
This is a very good question. Until now, all the adjuvant trial performing oncogene addicted tumor were positive in terms of DFS. We have a demonstration of an overall survival benefit for osimertinib in the ADORA trial. It's a little bit early for the other trial, but the magnitude of DFS benefit, which is I think in adjuvant setting, a significant endpoint in itself, justified to give the drug as a standard of care now. So for the other oncogenic addiction, it's sometimes difficult to run a trial due to the rarity of the genomic alteration. Nevertheless, there is an ongoing trial for the ROS1 positive non-small cell lung cancer with taletrectinib. So I think for the fusion, due to the activity of the TKIs, I think probably all the study will be positive. Coming back to the first part of your question about the muscular toxicity of alectinib, we have sometimes a CPK elevation with alectinib. It's not so frequent, and sometimes we have to stop the drug and to restart at a lower dose level. It is generally related to a strong physical effort, and it's not a usual limiting toxicity, but it can occur, and we have to check the CPK, especially if there are muscular pain.
So, John, again, Maurice went through really the amazing results now that we're seeing with lorlatinib now, 55% 7-year PFS from the CROWN study. I guess it's never going to make its way into the adjuvant setting because of concerns, I guess, about the potential neurotoxicity or psychiatric toxicity. It's kind of amazing to think you could see a survival benefit with adjuvant alectinib when you have first-line PFS like this with metastatic disease. John, anything you want to say about lorlatinib? And again, you have a lot more experience than the average doc in practice using it. It has a little bit of a questionable reputation. I hear cases of people, personality changes, et cetera, et cetera. For practical purposes, what's life like on lorlatinib?
Yeah, I think the study you're pointing out, the CROWN study, really changed the game for me as this later data started reading out. I think a lot of lung cancer experts previously would start with the second generation drugs, which are a little better tolerated. And the thought is we could always go to lorlatinib afterwards. But when you look at the progression-free survival of the second-gen drugs, tends to be around 30 months plus a little bit. They really don't compare with what we're seeing with lorlatinib. I mean, the median PFS is north of 7 years. 7 years. I mean, that's really amazing. So when that data came out, actually when the 5-year data came out, I think a lot of other people, it wouldn't surprise me if Maurice as well sort of changed and said, okay, we've got to start with the drug. Now, what we've learned with lorlatinib, there is more neurocognitive side effects than with drugs like alectinib. There's a little more edema. This is probably an off-target toxicity from what are called the NTRK or TRK-B receptor. But it's manageable. A lot of times you have to drop the dose. We start at 100. Sometimes we'll go down to 75. Occasionally you have to go down to 50. But it is manageable. It does respond to dose reductions. And as you gain experience with it, I think most people find that patients continue to do well with the dose reductions and it can be managed. You just have to warn patients about the side effects.
Let's talk a little bit about ROS1 fusions. And Maurice, your talk, you go through kind of how this has evolved, starting out with entrectinib. I was just flashing on a case of a patient we had presented in one of our conferences who presented with locally advanced, non-resectable, non-small cell. The patient was sent for chemoradiation and durvalumab, and then they found the patient had a ROS1 fusion, and they were like, do we give durvalumab or not? I'm curious what you would have done in that situation. But maybe you can talk a little bit of what we know about entrectinib, obviously very effective, but also in terms of its tolerability profile.
Well, entrectinib is clearly a very active drug in ROS1 positive non-small cell lung cancer, very good response rate, good CNS penetration, and we have two main issues. This is the first, the duration of response, which seems to be shorter than for the next generation TKI targeting ROS1, and the safety profile, which is mainly linked to TRK-B inhibition in the CNS, leading to dizziness, some dysgeusia, and therefore this is probably and weight gain with edema also. So this is not a very easy drug to manage, given the fact that we have access to a new generation of drugs now with probably a better benefit toxicity ratio. So I think this is an active drug, but this is probably now this will be replaced by the new generation drugs.
Of course, John, we also have repotrectinib, another ROS1 inhibitor, again with a excellent efficacy. But we were talking also about the CNS activity of entrectinib that initially got people interested. And repo is being looked at also in a phase 3 trial. Anything you want to say about these first generation agents, particularly in terms of tolerability? Do you agree with, it sounds like Maurice is saying this is going to be maybe of historic interest now that we have these new agents. And right now, John, how would you manage this case I was talking about of a patient locally advanced non-resectable ROS1? Would you give durvalumab or a ROS1 agent?
Yeah, well, first of all, I do think the first generation drugs should become, sort of historical interest. But, I see patients are still sometimes being treated with crizotinib. Given the CNS activity of that is so much lower and the overall activity is so much lower, I really recommend people switch to the newer drugs. I tend to reach for taletrectinib first, given the recent data. There's strong data, coming out with newer drugs than that from Nuvalent and others as well. In the setting of stage 3 disease, what we call the Pacific setting after chemorads, we know that immunotherapy is not likely to be active for tumors like ROS1. But right now for stage 3 disease after chemorads, a TKI is not yet approved outside of EGFR. Even though that's what logically you would want to use. So, what I do in this setting is I really look hard and see is there some small evidence of metastatic disease or questionable metastatic disease, and if so, I'll keep the TKI going. But if you really do believe the disease has been eradicated, right now a TKI is not on label, unfortunately. It's going to take a long time to do those studies. They may never get done.
So, Maurice, can you talk a little bit about what we know about taletrectinib? John says this is the agent he'd like to be able to use. We have this TRUST-1 and TRUST-2 study. What do we see here in terms of efficacy and tolerability?
Well, taletrectinib has been assessed in 2 pivotal phase 2 studies, TRUST-1, which has been conducted in China, and TRUST-2, which was a more global study. And had they shared the same criteria in terms of patient inclusion, eligibility criteria, and method of assessments, the results have been pulled together. And this is clearly in TKI naive patients, some having been treated with chemotherapy, but in TKI naive patients, the level of activity is very impressive. 90% response rate, median PFS close to 4 years. And so in terms of tolerability, the main toxicity is a short duration of GI toxicity at the beginning of the treatment and transaminase elevation, but with few grade 3, in fact. And the liver toxicity can be easily managed with dose reduction, dose interruption, and restart at a lower dose level, 400 milligram QD. So, clearly, with this data, I think taletrectinib is probably the treatment I would select for the frontline treatment of patients with ROS1 positive advanced non-small cell lung cancer. Good safety profile, very high level of activity, and also good CNS penetration.
So, John, anything you want to add to that great summary of what we know about this exciting agent? What are some of the ongoing studies? What are they looking at right now?
Yeah, no, I agree. It's the drug I would use in the first-line setting. Median PFS coming up on 4 years. That's really impressive. Drug's been tolerated well. Transaminases are something that is a laboratory abnormality, but there haven't been cases of frank liver failure that I'm familiar with, at least. So I think it really has just been keeping an eye on those LFTs. We've seen some CPK elevations as well. I'm excited to see the results of the adjuvant study. So to their credit, they are going through and doing the adjuvant study. I know it's going to take a long time given that this is a rare population, but that is a wonderful benefit for patients if this does become available in the adjuvant setting, as I expect it probably will be.
So, Maurice, if you could, would you use a taletrectinib in the adjuvant setting, outside a protocol setting, if you had access to it?
I think we would have that access to taletrectinib in adjuvant setting. I think I would not before the results of the trial. The trial has just started a few months ago, so I think I would wait for the results because if you follow up very carefully your patient after a surgical resection, probably you will be able to detect very early recurrence, maybe with ctDNA, and therefore to start very early taletrectinib in the metastatic setting. I would wait for the study results, probably.
I've been asking people for at least 5 years, probably longer, would they use a RET inhibitor in the adjuvant setting? Everybody says, oh, we want to wait for the trial. Now we have the trial, so everybody's going to use it. But it's just really, people get frustrated because they want to use it. Any thoughts about this other exciting ROS1 agent, zidesamtinib, John? Any potential advantage or disadvantage compared to taletrectinib?
Yeah, this may have some tolerability advantages here. It's a very good drug. Now we don't have as much data. It's not as mature as we have, for taletrectinib. One of the things we know is it's very good for resistance mutations to a lot of the earlier drugs. It works evenly in heavily pretreated patients. For ROS1, the common resistance mutation is this G2032R. I'm actually treating somebody with this right now with this exact resistance mutation, and the drug has really good activity. It's notable that in the second line setting, the PFS is not nearly as long as in the first line setting. But this drug, I think, will be competitive with taletrectinib. It's another really good new TKI with good CNS penetration and good tolerability. So I think when the full data reads out, I think it's going to be right there. If not a better tolerability profile than taletrectinib.
All right, so here's a summary of what we've been talking about. We're going to finish out, and we've been talking about it, of course, is the Libretto 001 phase 1/2 trial. Can you talk a little bit about that, Maurice, and also, of course, the adjuvant study in Libretto 432 trial?
Well, the Libretto 432 trial assessed selpercatinib in adjuvant setting versus a placebo after adjuvant chemotherapy, if indicated. This was a very small study in terms of sample size because the expected difference was very high, and really the benefit in terms of DFS, both in the primary analysis population with stage 2 and 3, but also in the ITT population, was extremely impressive and very similar to that obtained with osimertinib in the ADAURA study with hazard ratio of 0.17. This is clearly in terms of efficacy, in terms of DFS benefit, and also in terms of CNS relapses, a very active drug in adjuvant setting. In terms of tolerability, because we are in adjuvant setting and probably the side effects are probably more difficult to manage in adjuvant setting than in metastatic setting. This is the side effects are not so trivial because we have 2/3 out of the patient treated who experience a grade 3 or more adverse event. We have 17% of the patients who had to discontinue selpercatinib due to toxicity. We have a lot of patients who had dose interruptions. So the safety profile, we have to pay attention for the safety profile for those patients, especially in adjuvant setting with hypertension, with edema, with transaminase elevation. some very specific adverse events with effusions also. So the treatment should be given for 3 years. And I think 3 years is probably a long duration of treatment for the patient with selpercatinib.
John, any thoughts about this and what kind of a challenge, as Maurice points out, the adjuvant setting is very different in how we look at toxicity. Also, I've heard cases of KRAS fusion. I don't know if when you see that, or do you see it more in with a lot of bulky disease in the metastatic setting? Do you ever see it in the adjuvant setting? Any comments on sort of the life-on adjuvant selpercatinib, John?
Yeah, I think it's a challenge often because, patients feel like, well, the tumor's been resected. Why do I need to, continue this drug? But really with these oncogenic drivers, we know the likelihood of metastatic disease that's microscopic is really high. The recurrence rates are really high for these drugs. So I think the benefit is huge. Now, one of the unusual side effects for selpercatinib, and there's less data, but we think it also happens with pralsetinib, is what's called a KRAS pleural effusion. So this is when you see a pleural effusion and you might think, well, this is recurrent disease, but you tap it and you can send it off, for lipids and other workup. And, it comes back that it's KRAS, it's lymphatic drainage, essentially. Now, on top of that, we recently reported that you also get KRAS pericardial effusions. So we've had a number of patients with selpercatinib where suddenly you see a pericardial effusion. You think it might be recurrent disease. You tap it, and it's a KRAS pericardial effusion with the same biology. So this is just important that people know this is a side effect. I've gotten a number of patients who were referred with the assumption that it's metastatic recurrence, and it's not. It's just a side effect of these drugs. It responds with dose interruption or de-escalation.
So final point. So Maurice, when we've been talking for years now about treatment of metastatic RET fusion positive disease, and I've always kind of heard the story, well, it's a coin flip between pralsetinib and selpercatinib, but then you presented some data I wasn't aware of suggesting patients on pralsetinib have significant issues with infections, which I hadn't heard before. Sounds like pralsetinib's kind of going down, if not out. Where is pralsetinib, and how much of a problem are these infections that we're seeing with this phase 3 trial, Maurice?
Well, you're right. I think pralsetinib and selpercatinib have a very similar range of efficacy against RET fusion positive non-small cell lung cancer at metastatic stage. Nevertheless, the safety profile is quite different. Pralsetinib has more hematological toxicity, and this is probably one of the reasons why during the phase 3 study there were more side effects in terms of infections and severe infections, including grade 5 events, and especially opportunistic infection, leading to think that pralsetinib probably can impair significantly the immune system, not only by the neutropenia, but also probably for the cellular immunity. And this was probably not expected, and it was just apparent during the phase 3 trial, and in comparison with chemotherapy, which is a little bit surprising, a TKI versus a chemotherapy, and in fact more side effects in terms of infection for the TKI. So when you have this in mind, I think probably the safety profile of selpercatinib is more favorable.
So things change with time as we follow them. So John and Maurice, thank you so much for working with us today. Audience, thank you for attending. Be safe, stay well, and have a great night. John, thank you so much. Maurice, thank you so much. Have a great night.
Thank you.
Great seeing you as always, Neil.